This presentation is based on a paper co-written with Anne Horn and Pat Radford and published by Routledge in the first edition of the Handbook of Child and Adolescent Psychotherapy, edited by Monica Laniado and Anne Horn. Non-intensive psychoanalytic psychotherapy, usually once, sometimes twice weekly sessions, forms the bulk of the work of the child psychotherapist. Yet surprisingly little has been written about it as a specific form of treatment distinct from intensive psychotherapy, about the technical issues involved, or about the particular benefits of non-intensive vis-à-vis intensive psychotherapy with children and adolescents. Similarly, the assessment of children and adolescents figures infrequently in the psychoanalytic literature. Much has been written about the very detailed diagnostic profile originally devised by Anna Freud, but not about the styles of assessment more common within the public sector. The practice of child psychotherapy has its roots in and is informed by the theories of psychoanalysis. Child psychotherapists are trained in both intensive and non-intensive psychotherapy, but many find working non-intensively harder and more demanding, both technically and intellectually. The therapist can feel swamped by large amounts of biographical data and session material, and anxious about being able to hold all this in mind if she's working with a lot of children in once-weekly sessions. She often cannot afford the luxury of waiting until the next session, as one can in intensive work, to pick up on something in the child's material, as it may get lost more easily in the interim. Similarly, there may be felt to be a pressure of time available in non-intensive psychotherapy for the therapist to think through how to respond interpretively. Non-intensive psychotherapy is the treatment most usually offered within the public and private sector. Some child psychotherapists consider this the most appropriate treatment frequency and feel that intensive psychotherapy is only warranted in very particular circumstances. They believe that there are very few cases where significant improvements cannot occur in non-intensive work, especially if the transference is a major focus of the work, and that in certain cases, non-intensive psychotherapy is the treatment of choice, and more intensive work is not only contraindicated, but could be counterproductive. Others feel that there are definite limitations to non-intensive psychotherapy, and that ideally more intensive work would be more beneficial for many children. Such people suggest that non-intensive psychotherapy is usually recommended for more pragmatic reasons, such as scarcity of resources within clinics in the public sector or constraints within the child's family. Some consider that the different treatment frequencies are best suited to particular types of disturbance, whereas others see the difference between intensive and non-intensive work as lying not in the child's pathology, but in the therapist's capacity to identify with the child's inner world and to be not only a transference object for the child, but also a developmental object with whom the child can identify to help him to grow. These differing views have not been widely discussed, partly perhaps because of controversial political issues and value judgments, and partly because of the difficulties in gaining outcome research evidence. Due to the wide provision of non-intensive as opposed to intensive psychotherapy, a large number of children can be offered help. This would seem to offer benefits to the community as a whole. It's also important, however, to try to consider carefully what might be most beneficial for each individual child. Some recent studies have begun to consider this question. However, far more research needs to be done before more definitive statements could be made about what one can and cannot expect to achieve in non-intensive psychotherapy with children and adolescents, and where it is most likely to be beneficial. The less frequent contact between child and therapist in non-intensive psychotherapy, in comparison with intensive work, can make the therapeutic endeavour more manageable for some children and/or their families. For some, it may be all that is necessary to help them to return to the path of normal development. For others, it may not offer the depth of experience that is required to affect the severity of their disturbance, and intensive work may be necessary. Some preliminary findings about the successful outcome of child psychotherapy concern not only the frequency, but also the length of treatment. In their outcome research into the detailed records of 763 closed treatment files at the Anna Freud Center, Fonagy and Target found, quotes, "In children younger than 12, intensity but not duration of treatment was related to good outcome. In contrast, they found that the reverse was true for adolescents. The length of treatment rather than its frequency seemed linked to the benefit gained. This is of particular importance when one takes into account another of their findings, namely that there may be more of a likelihood that a non-intensive psychotherapy will be ended prematurely, either by the child or the parents. Boston and Lush, in their study of 31 adopted and in-care children in psychotherapy, reported that 12 out of the 19 children in once-weekly work dropped out of therapy early, in contrast to only 1 of the 12 children in twice or 3 times weekly therapy. Added to this is the well-recognised fact that adolescents have a tendency to drop out of treatment early, often for developmental reasons, which I will refer to later. The tendency for children in non-intensive therapy to drop out of treatment is likely to be affected by their own and their parents' motivation towards the therapy. Sometimes once-weekly work is offered to a child when the parents' motivation is not very strong. In such a case, premature ending of the therapy by the parents would not be at all surprising. Also, the parents or other caregivers of the child are far more likely to support the child's therapy if they feel supported themselves by the therapist or another clinician. This support will affect their attitude and motivation towards the child's treatment. The parents of children who are undergoing intensive treatment may not only be more motivated towards the child's therapy in the first place, but may also be more willing to engage in regular work themselves to support the therapy and gain support for themselves, as well as to consider their own impact on the child. Consideration needs to be given to the impact of the longer gap between sessions in non-intensive psychotherapy. How well will the child be able to manage between one session and the next? The therapist needs to take this question into account when assessing the child and deciding on the appropriate treatment frequency. A child with a relatively strong ego will probably cope quite well, but a child who is more fragile and finds it harder to contain feelings of anxiety, aggression, dependency, separation and loss may be thrown severely off balance. Such a child may need more help from the therapist to seal sufficiently by the end of the session in order to feel contained and strong enough to carry on his life outside of the therapy without too much anxiety until the following week. The therapist's sensitivity to the child's need to manage during the gap between sessions and the child's capacity to do so is extremely important and will alert the therapist to be careful about how and when to take up anxiety-provoking issues, especially towards the end of the session, and about how to support the child's appropriate defences and capacity for healthy mastery, whilst at the same time conveying to the child acknowledgement and understanding of the feelings of rejection, anger, fragility, loss, etc., that may feel overwhelming in the absence of the therapist. The supportiveness and sensitivity of the child's home environment is another factor in enabling the child to manage the gap between psychotherapy sessions. This emphasises again the importance of establishing a good working relationship with the child's caregivers. Assessment of the range and flexibility of the child's defences is crucial in terms of considering the appropriate treatment frequency. If the child's defences are very restricted and rigid, non-intensive contact with the therapist may be insufficient to help the child to loosen them. because defences can become consolidated between sessions. Similarly, there may be less opportunity for thorough working through, and there can sometimes be a tendency for a stop-go process in one's weekly psychotherapy. However, many children will be able to maintain a flow in the therapeutic work and make excellent use of non-intensive psychotherapy, especially if transference is a major focus of the work, if they are motivated to want help and are able to establish a treatment alliance with the therapist, and if they have the capacity to contain anxieties and feelings between sessions and a relatively strong progressive developmental push. The next session is entitled Thinking About Assessment. The aim of assessment is to consider the nature and extent of the child's disturbance and then to decide on the most appropriate form of treatment. The child psychotherapist does this by taking into account all aspects of the child's internal and external world, the developmental stage he has reached, and the child's problems as perceived by the child himself and by significant adults in his environment, such as parents and teachers, as well as his strengths and capacities. The child psychotherapist needs a theoretical framework which will help her to make use of all the material obtained during the assessment process. External material from meetings with the parents and or social worker, and perhaps a report from the school, as well as the material about the child's inner world, which is obtained from the individual assessment meetings with him. Projective testing by a clinical psychologist can also offer valuable insight into the child's internal world. If other psychological tests are also available, they can indicate whether the child is reaching his intellectual potential or underachieving, perhaps due to anxiety, and whether there are specific difficulties in particular areas of his cognitive functioning, which may be addressed by the psychologist and the school together. One theoretical framework, the diagnostic profile devised by Anna Freud, helps the diagnostician to focus attention on the many different facets of the child's personality and on the effects of the child's development and problems on his mental, emotional, and social functioning. In addition to considering the external environment of the child, his family, friends, school, and the impact of actual experiences on his development, the diagnostic profile pays special attention to assessment of the child's internal world in terms of rather a long list of things. His ego capacities and ego strength, including the range, flexibility and effectiveness of his defences, his capacity to tolerate and contain anxiety and frustration, and his capacity to differentiate between reality and fantasy, and between self and other, his capacity for attachment and for relating, the quality of his relationships and identifications, and his capacity for concern, the nature and extent of his anxiety, his narcissistic vulnerability, the relative strength or fragility of his sense of self, his level of self-esteem and his means of regulating it, the development of his superego, his conscience and ideals, his tendency for regressive or progressive development, the nature of his conflicts, wishes and fantasies, his developmental level overall, and the evenness or otherwise of his progress along specific lines of development. The developmental lines, also devised by Anna Freud, are supplementary to the diagnostic profile and are particularly useful to consider in assessing young or very severely disturbed children. They provide a picture of the child's evenness or unevenness of development at the time of referral and help the diagnostician to be specific about which areas of development are delayed, age-appropriate or precocious. Although it is sometimes not practical to carry out a full diagnostic profile, as it's a very time-consuming process, it is extremely useful to have in mind the kind of diagnostic thinking that informs the profile in order to be alert to all the different aspects of the child's internal and external world that need to be assessed. When undertaking an assessment of any child or adolescent, the child psychotherapist looks for deviations in the child's behaviour from the generally expected norm for his age, gender and culture. She uses her knowledge of typical development to pinpoint the deviations, irregularities and deficiencies shown in such aspects as relationships, behaviour patterns and symptom formation. So, for example, a boy of 9 should developmentally have reached latency, having made some resolution of his Oedipal conflict by identifying with his father, feeling protective towards his mother, and competing actively with peers. He should be looking forwards to becoming a teenager, able to tolerate more frustrations, developing further sublimations, increasing his personality gains, and using his defences economically in order to keep anxiety within manageable levels and to maintain a reasonable balance between his psychic structures of id, ego and superego. Such a boy of 9, of a middle-class, professional family, would normally be an active participant in school, enjoying a range of activities and hobbies with friends, mostly boys, and be more concerned with their admiration than that of his parents, whose opinions have become superseded by those of his teachers and peers. He would have effective defences against overstimulating sexual and aggressive fantasies, but be able to find outlets for instinctive urges through adequate sublimations. So, for example, if one of his interests is football, he would enjoy playing it, support a team, he'd idolise certain players, and collect football stickers, etc. He would be more consciously interested in the external world than in his inner world of abstract ideas and introspection. He would enjoy his physical prowess and the development of his body, but would also be interested in intellectual achievements, finding satisfaction and fulfillment from both types of endeavour. In the assessment process, sensitively handled meetings by a social worker or child psychotherapist with the parents are extremely important for a number of reasons. They give the parents a chance to talk about their concerns for their child and to feel listened to and understood by someone who wants to be helpful. This enables the parents to be more willing to think about how their own difficulties might be affecting the child, and to consider engaging in ongoing work with a professional during their child's therapy and to support it. The meetings provide an opportunity for the clinician to build up a picture of the child's history, developmental background and family setting, and of the parents' perceptions of the child, all very important material for the assessment. They will help the diagnostician to assess the strengths of the parents and their capacity to cooperate in what might be recommended to help the child. They allow the clinician to discuss the assessment procedure with the parents and to think with them about how best to talk about it with the child. For example, it may be important to let the parents know that if the child is too anxious to separate from them, it's quite all right for them to join the child in the room, and one can discuss how best to negotiate this without being intrusive. It's helpful for the child psychotherapist to see the child 2 or 3 times, as this gives time to build up a picture of the child and of his internal world. And it's often informative to notice how the child presents himself in the different meetings. For example, familiarity with a setting and with a diagnostician in a second meeting may help the child's initial anxiety to decrease, or it may increase, perhaps as a result of intensification of transference phenomena. It's always of interest to compare a psychologist's report and/or a school report with the child psychotherapist's impressions of the child. If the impressions of the child are very different, this may be due to the nature of the child's anxiety. Does the child feel safer and more contained in a structured setting, such as school or when doing a psychological test? Is the child very fearful of getting things wrong, causing an increase in his anxiety in the school setting or the psychological testing? Is the gender of the different professionals relevant in terms of the child's feelings about himself and ways of relating? When setting up an assessment, the diagnostician is careful to find appropriate tools in relation to the child's problem and age, which will facilitate the expression of his internal world. For example, verbal communication is more difficult than symbolic expression through play for the younger child. So some toys should certainly be available. These might include family figures, ideally corresponding to his actual family in terms of number and gender of siblings, toy animals, including some which are thought of as fierce, like a crocodile or tiger, that could act as a means of communicating fear, anger and aggression, some modelling clay, such as plasticine, drawing materials, perhaps some cuddly toys. With older children, other age-appropriate small toys could be included, such as toy cars and ambulances, police cars, dolls and soldiers, etc. For the adolescent, drawing materials are probably all that is necessary. Some child psychotherapists feel it's important to offer a fairly limited number of toys so that the child remains focused and does not either feel overwhelmed by the variety or use the range of toys for defensive purposes. But other therapists, including me, consider that whatever the child does with a wide variety of toys available will be illuminating in terms of assessing his defences and his capacities to relate, to play and express his conflicts. The same goes for treatment itself. For example, Eddie, an 8-year-old boy who was confused and frightened about growing up as a boy, was able to express and work through his conflicts by using girls-specific toys and toys usually used by much younger children that were available in the room for everybody's use in a main toy cupboard, items that one would have hesitated to provide specifically for Eddie. An assessment is a limited and closed process and is therefore different from treatment. The child psychotherapist has a unique role in speaking for the child and considering how best to help him. But unlike treatment sessions, she can make wider use of the outside information that has been supplied at the time of referral. The technique used in an assessment is usually also rather different from what happens in treatment sessions. While the transference may be recognised by the therapist during the assessment, many therapists do not consider it helpful or wise to make explicit transference interpretations because the assessment process is time limited and there will be no room for exploring the child's feelings in an ongoing relationship in a way that will feel safe for him. But since it's likely that some transference relationship will be established during the assessment, it's very important to let the child know from the beginning if he will only be meeting the therapist a few times, so that he is prepared for the probable loss of her at the end of the assessment. If therapy is not immediately going to follow the assessment, it's also important to recognise that the child's defences need to be kept intact or helped to be reinstated in order to help him to contain his anxiety and reduce the possibility of harmful acting out. There are a number of simple techniques which can be useful in helping the child to engage with a diagnostician and communicate his concerns, especially if he's having difficulty in feeling safe enough to express himself either through play or words. For example, if his anxiety arouses defensive inhibition. Most importantly, the diagnostician will want to relate to the child in a friendly way, acknowledging that it probably feels rather nerve-wracking to talk to a stranger. If the child has already been seen by a number of other professionals already, the sense of, oh no, not another one, can be verbalised by the therapist in an empathic tone that might relieve the initial anxiety and resistance, help the child to feel more ready to engage with the assessment, and feel freer to express his resentment. It's helpful for the diagnostician to ask the child if he understands why mum or dad has brought him, and to suggest he might have been a bit worried about what kind of person she would be. This gives an opportunity to explain to the child about the assessment process, to get to know what it's like to be you, to see if we can think how best to help you, and to prepare the child that he will be seeing the diagnostician just a certain number of times. It also helps the child to feel that the diagnostician understands he feels anxious, and it gives him the opportunity to express his fantasies about her and the assessment. It's not uncommon, for example, for some children to worry that going to a clinic for an assessment will be like going to hospital, and that something horrible will be done to their body. Other children, especially those who have been abused or who have got into trouble because of their behaviour, will worry about being asked a lot of invasive questions and may fear that they have been brought because they are bad and that they're going to be taken away from home. It's very important to show interest in the child's positive achievements and in the things he likes doing, as well as what worries and frightens him. In fact, many children and adolescents are unable to feel safe enough to communicate their concerns about themselves until they've experienced the therapist's positive interest in their strengths and in the things they enjoy. One useful and well-known technique in assessment, especially with children who find it hard to express anything pertaining to their inner world, is to invite the child to have a game and imagine that he has 3 wishes to do or have whatever he would like. This can provide valuable insight into the child's fantasies and open up discussion about them. However, some children are so anxious and heavily defended that they cannot allow themselves to reveal anything in these 3 wishes. They may reply with, "don't know," or simply use their wishes to have new toys. I stumbled on an elaboration of the 3 wishes game out of desperation when assessing a particularly anxious and heavily defended boy. Darren, aged 14, had sexually abused his 9-year-old sister. He had been stealing money and cars and had become so aggressive and out of control that his mother had placed him in local authority care. In the first assessment meeting, it was clear that he felt enormously ashamed and also afraid of being told off. Although I verbalised this anxiety, he remained silent with his eyes averted. I was unable to help him feel sufficiently safe to talk to me, however hard I tried, and the 3 wishes game didn't help him to engage. In desperation, I suddenly had the idea to suggest a variation of the 3 wishes, namely not what he would like to have, but what he would like not to have had. I wondered if he could imagine having a time machine, like Doctor Who, so that he could go back to the past and change 3 things that had already happened. I said you could go back to when you were 10, or when you were 8, or when you were 5, or when you were 2, whenever you like. To my surprise, he responded, for the thing with my sister never to have happened, and for my dad not to have kept beating me, and to have had a nice dad who wouldn't have left us. It then became possible for Darren to communicate more freely. Another technique, drawing a family tree with the child, and with younger children perhaps also using the toy family figures, can help him to feel freer to talk about the important people in his life. One can then ask, who's best at, in your family, keeping people safe, helping you if you're cross or sad, understanding how you feel, etc. This often leads on to a discussion of whom the child does not feel safe with, helped or understood by. This can provide material about how the child feels about himself and about significant others, and about how he perceives others feel about him. It can also be useful to ask which person the child would want to have with them on a desert island. This can indicate to whom the child feels most attached and how and why, as well as points to the nature and quality of his relationships. During an assessment, the diagnostician observes how the child relates, plays, communicates, and protects himself from anxiety. By observing and participating in the play, the therapist will become aware of the underlying anxieties and fantasies. In addition to wondering about the possible meanings underlying the material and how he relates with her, the diagnostician will also be alert to the specific relationship between the child's psychic structures. This facilitates a dynamic understanding of the child's conflicts between instinctual needs and the defences and prohibitions against them. The previous history and experience of the child may well be affecting this balance and may be illustrated in his play. The defensive structures may have attempted an economic distribution of the ego's resources to deal with the anxiety arising from these conflicts, and the child may have found a compromise solution through symptoms such as learning difficulties, behaviour problems, encaprices, inadequate social relationships, sleep and eating disturbances, etc. For example, Bobby, aged 9, a very inhibited little boy who suffered from terrifying nightmares and bedwetting, examined the wild animals in his first assessment meeting, but was defensively unable to notice or play with the crocodile. At the second meeting, when he had developed the beginnings of trust in the therapist, he was able to bring the crocodile into his play, making it bite the giraffe quite fiercely. This demonstrated the interplay between his psychic structures in relation to one of his major conflicts, namely his instinctive urge towards his biting impulses and his superego fear of them, as well as his ego's defensive strategy of avoidance for trying to deal with this conflict. As well as being alert to the child's conflicts and difficulties, the therapist should also aim to assess the child's underlying strengths and his capacity for sublimation, mastery, and progressive development. For example, Jane, aged 9, quickly enacted a fight between the family figures. This seemed to arouse intolerable anxiety, so she turned to drawing monsters instead, which gave her more sense of control of her aggression. However, this also became so frightening for her that she had to obliterate her picture by scribbling all over it to cover up the monster. The therapist noted how very frightening her nightmares must be. Jane nodded, looking rather relieved, and then decided to write a just pretend story, which she agreed was about one of her dreams. Being able to contain her fear by writing about her dream showed some potential for mastery and progressive development. One of the important factors in working with children is their capacity for growth and progressive development. Insofar as the problems and symptoms have delayed their progress and perhaps have presented a picture of regression, the therapist should be able to clarify from the child's material to what extent he can show a wish to move forward. For example, Jill, aged 11, presented with encaprices and related to her mother in endless battles. In spite of good intelligence, she had learning difficulties and was unable to compete or participate in her peer group. However, in the assessment, she spoke of her wish to be a champion gymnast and to be admired by her peers for her prowess. So although she presented with very toddler-like symptoms and ways of relating, more age-appropriate wishes were available to her. The diagnostician will also be alert to the child's ability to tolerate frustration and to contain anxiety, factors important in the choice of treatment. The child's feelings about himself, for example, loving, hating, turning aggression against himself, feeling a failure, or respecting himself, are of importance in terms of his capacity to make use of therapy. The diagnostician will be particularly interested in the child's relationship to the most significant people in his life, especially his parents and siblings, both in terms of his actual observable relationship with them and also, most importantly, as perceived in his inner world. His belief or fantasy about how much he is loved and is lovable, and how much he is able to love, will have a bearing on his capacity to relate to the therapist and make use of the transference as a tool in therapy. In the assessment, this will be evident in how the child relates to the therapist, particularly between one session and the next. For example, Sam, aged 5, reluctantly left the first session feeling inappropriately angry towards the therapist. The therapist thought he might well be very reluctant to come to the next session because she had become as if a witch in his eyes. How far his reality strength would enable him in the second meeting to overcome his fear and hostility and thus recognise the benign aspects of the therapist would be invaluable in deciding on the most appropriate treatment frequency. If his fantasy held sway and his anxiety increased, this would demonstrate the inadequacy of his defences against his aggressive impulses and indicate the need for greater frequency of sessions. Following the assessment sessions, the material from the meetings with the child and the information from the parents, school and other sources are now brought together. On the basis of these, the child psychotherapist can make a diagnostic formulation. Does the child have a neurotic conflict, a developmental disturbance, a borderline or atypical disturbance, a psychotic disturbance? Is the disturbance due to trauma? Are the conflicts internalized, or are they being affected by ongoing environmental factors? How severe is the disturbance? The diagnostic formulation will take into account the nature of the child's past and current environment, his strengths and weaknesses, the nature and intensity of his conflicts and anxiety, his capacity for relating, for coping with anxiety and frustration, for defending himself age-appropriately, and for progressive development. All this will enable the child psychotherapist to consider the most appropriate treatment. This may well be non-intensive or intensive individual psychotherapy, often with a recommendation of concurrent work with the parents, but this is not always the case. Sometimes it may be appropriate to recommend remedial teaching, work just with the parents, family therapy, supportive counselling, a behavioural programme, change of school or foster placement. Whatever recommendation is chosen, and sometimes a combination of interventions will be appropriate, it is important to try to validate the assessment by follow-up in order to enhance a high standard of diagnostic skills. If the recommendation is for psychoanalytic psychotherapy, the child psychotherapist now has to begin to consider the frequency of therapy that is likely to be best suited to the child's needs. Consideration should be given to the parents' motivation towards therapy for their child and towards their own willingness to engage in thinking with a professional about their own and their child's difficulties. The nature of the parents' relationship and the situation of the family as a whole should also be taken into account. How will these be affected by a recommendation for non-intensive or intensive psychotherapy? How much support for the child's therapy can one realistically expect the parents to provide? So we come to the question of non-intensive or intensive psychotherapy. Very significant work can be done in non-intensive psychotherapy. It is an appropriate form of help for a large number of children and adolescents, enabling them to gain considerable benefit. However, there are some children for whom non-intensive psychotherapy is insufficient to address the depth and extent of their disturbance. It's very hard, for example, to tackle the widespread disturbances evident in borderline and atypical children in non-intensive therapy. And children with severe narcissistic disturbance need the long, slow process of intensive work to achieve internal change. Fonagy and Target suggest that children with severe or multiple pathologies require intensive treatment, and that children with generalized anxiety disorders, depressive disorders, or concurrent disruptive disorders respond significantly better to intensive therapy. Erna Furman considered that some children need the framework of the consistent investment and availability of intensive psychotherapy to feel sufficiently held and contained enough to tolerate, explore, and ultimately master the primitive states linked with severe ego weakness, arrest, and regression. She suggested that intensive work is necessary to help such children face and tame their primitive, unfused aggression. She says this applies to aggression against the analyst, helped by the built-in reassurance that he or she survived the patient's attack and remains available, as well as to aggression against the internal representation of the analyst, which can often survive the day-to-day interval between sessions, but is in danger of being destroyed during intervals of several days. Such primitive aggression is usually too threatening to face in psychotherapy, or can interfere with its usefulness or continuity, whereas in daily analysis it has a chance of being fused. Non-intensive psychotherapy may be particularly effective for children whose disturbance is not too severe or global. Having said this, child psychotherapists can bring about considerable change in non-intensive psychotherapy, even with extremely difficult cases. So perhaps the most important question is, how much change is necessary to help the child get back onto a developmental path and move onwards? When working with children, we do not aim for cure any more than can be aimed for realistically when we work with adults. What we aim to do is to help the child to return in a good enough way to the path of age-appropriate development. The debate about which children have most need of intensive... Sorry, I'll start that again. The debate about which children have most need of intensive psychotherapy appears to centre on the nature and extent of the child's disturbance and the child's developmental stage. So I'll start with looking at the nature and extent of the child's disturbance. The child who has developed a transient developmental disturbance with the appearance of symptoms and considerable anxiety, but who does not have a deep-seated emotional disturbance, will respond well to being offered help through a difficult time, especially through the therapist's understanding and verbalization of the child's feelings of shock, anger, sadness and grief, etc. Non-intensive therapy may be indicated for such a child. The child with mostly adequate functioning, but with a delay in a limited number of aspects of development, or with a relatively mild form of neurotic disturbance, can benefit well from non-intensive help. Erna Furman considered non-intensive psychotherapy to be the treatment of choice for children whose pathological formations are not phase-appropriate, burdening but not precluding progressive development, if the following factors are in evidence: adequate and consistent early mothering, developmentally appropriate parenting, disturbances during the oral and anal levels are absent or are related to external factors rather than pathology in the parent-child relationship, a positive drive balance with adequate drive fusion, adequate tolerance of anxiety, and flexible defences. Fonagy and Target suggest that a child suffering from a simple phobia, separation anxiety, or an obsessive-compulsive disorder gains as much benefit from non-intensive as from intensive psychotherapy. But it needs to be stressed that they are referring to the kind of disorder that falls within the range of neurotic disturbance and not those which are part of more pervasive and severe psychopathology, such as borderline, narcissistic or psychotic disturbance. Also, many people would say that it's very hard to treat an obsessional child successfully in non-intensive psychotherapy because of the rigidity and restricted nature of the child's defences. Non-intensive work may also be appropriate for the child who is not too severely disturbed and who is engaged in other interests and activities, such as after-school clubs, forthcoming important exams, friendship groups and clubs, that, if he had to forego for the sake of intensive psychotherapy, could undermine a centrally important aspect of his development. it may be very important for a child with somewhat precarious self-esteem, but not a severe narcissistic disturbance, to continue with certain activities that enhance his feelings of achievement and self-worth. And for some adolescents who need to focus on important exams, non-intensive psychotherapy may be an appropriate treatment, at least to begin with. More intensive work may be possible later. I've already noted how, in assessing any child or adolescent, it is important to recognise fully the healthy and adaptive areas of his life and to acknowledge these with him. We can become so used to the need to be alert to damage, anxiety and disturbance that we pay insufficient attention sometimes to adaptive and healthy aspects of functioning and instead have a tendency to pathologise. But a word of caution. The balance of the child's healthy and pathological functioning needs extremely careful consideration. I am certainly not advocating collusion with the child's or the family's omnipotence or resistance towards therapy, and I want to stress the importance of the assessment of priorities. It is not worth the risk of sacrificing the chance to effect lasting change to the young person's mental and emotional health and of alleviating severe distress in the long term in order to give him short-term relief. A very disturbed young person can always sit exams or start college later when he's on a more healthy developmental track and will be able to make good use of his improved state of mind and of his capacities for making healthier relationships. A very disturbed child may feel so frightened, anxious or humiliated about having psychotherapy that he is quite unable to countenance the idea of intensive work, which ideally he needs. But such a child might be able to accept the offer of non-intensive psychotherapy, and intensive work may become possible at a later stage if the child is able to experience therapy and the therapist is safe enough. And the second point about the difference between non-intensive and intensive psychotherapy concerns the child's developmental stage. Adolescents who are actively engaged in the adolescent process of separation, individuation from the parent figures may benefit from non-intensive work. Fonagy and Target's outcome study research found that adolescents did equally well or better in non-intensive treatment, in contrast to younger children who improved far more with frequent sessions. They say that the age of 12 marked a threshold beyond which children were somewhat less responsive to treatment, particularly on an intensive basis. But it should be noted that this research did not differentiate between the different stages of adolescence. It is generally well recognised that youngsters in early and mid-adolescence, roughly 12 to 15 years of age, are particularly hard to engage in the therapeutic relationship, whatever the frequency. This is due to the developmental process of adolescence. If therapy starts before they've begun to engage with the developmental tasks of adolescence, they are more likely to become emotionally involved in the therapeutic process and then be able to continue during early to mid-adolescence. If they start therapy in later adolescence, having either succeeded in accomplishing some of the age-appropriate developmental tasks or having recognised their failure to do so and experiencing anxiety about this, they are also far more able to feel motivated to engage in the work and in the therapeutic relationship. In some cases, it may be more possible to engage an adolescent in non-intensive therapy, where the intermittent contact with the therapist allows the adolescent more easily to go with the flow of the adolescent process. It is relevant here to elaborate on this developmental process. The young person who is age-appropriately engaged with the developmental tasks of adolescence struggles against the regressive pull to childlike dependence on his parents and makes use of a typically strong, progressive developmental push towards independence and separation from parents and other authority figures, towards taking ownership of his sexually mature body, and towards searching for a satisfying sense of identity, including a more stable sexual identity. In order to accomplish all this, the adolescent will swing between periods of intensely self-absorbed reflection and periods of quite dramatic action, including risk-taking and other potentially self-damaging behaviours. Anna Freud had such adolescent processes in mind when she expressed her caution about intensive therapy in adolescence. She wrote, quotes, "To try and analyse an adolescent in his phase of successful detachment from the past seems to be a venture doomed to failure," close quotes. However, Anna Freud saw intensive psychotherapy as both indicated as well as urgent in cases where the adolescent had withdrawn from engaging with the developmental process of adolescence. For example, there are those who have broken down during the strain of struggling with the age-appropriate developmental tasks. There are some with severe narcissistic disorders who require the long, slow process of intensive work to be able to feel safe enough to address their difficulties. And there are some who are so developmentally delayed that they have not yet been able to enter the developmental phase of adolescence, even though chronologically they would be called adolescent. Such young people have the level of disturbance that requires skilled, intensive intervention, although this should only be recommended if the young person's environment is sufficiently containing and supportive to hold him during periods of intense stress, regression, and the inevitable acting out. As well as assessing what is the most appropriate treatment frequency for a child and what he can manage, one also needs to take into account what is manageable for the child's parents and family, and if he's in local authority care, what is feasible for the network of professionals responsible for him. Intensive psychotherapy may not be manageable for a child whose parents face too many obstacles in trying to combine bringing the child to his sessions and caring properly for the rest of the family. There may be other children in the family whose needs also have to be considered, and the parents' relationship may be undergoing a great deal of stress. The child may have very young, ill, or troubled siblings who need a lot of attention from the parents, and there may be no other adults available to help with the family in order for the child to be brought to frequent sessions. The length and awkwardness of the journey and the long working hours of some parents often make anything more than once weekly therapy practically impossible. For a child in such a family, non-intensive psychotherapy may be the most appropriate intervention. If a situation arises where there is too much stress or resentment in the family about the child's attendance in therapy, the child's capacity to feel free to build up a good enough relationship with the therapist will be undermined, and the parents are likely to be less supportive of the child's therapy, which is a very important factor for not prematurely ending treatment and for a favourable outcome. Similarly, if the parents are very ambivalent about the child's therapy because of the strain it puts on them and the family, it will be hard for the child to feel free to express negative feelings about his therapy to them, because then the parents may well feel justified in ending the therapy. So non-intensive psychotherapy may be indicated for a child in the context of his particular family. However, if the child urgently needs intensive help, it is vital to try to talk to the parents in a way that is sensitive to their needs and the needs of their family, to see if there are any means by which to make it possible for the child to have the frequency of therapy necessary to help him. I have emphasised the importance of the child psychotherapist's careful assessment of the child and family situation in order to arrive at the most appropriate recommendation for frequency of sessions. Non-intensive psychotherapy will often be considered the most suitable and appropriate option. But where it is assessed that intensive psychotherapy should be the treatment of choice, It may still be that non-intensive work is the only available possibility because of scarce resources or environmental constraints. What I wish to underline here is the importance of considering at any one time what is in the best interests of the child in the context of what is also manageable for the family. It is important to keep alive the possibility of arranging intensive psychotherapy in those cases where it's clearly indicated, but we should also be alert to the need for flexibility of movement between treatment frequencies in working with any particular child. So a child in non-intensive psychotherapy may reach the point where he or his carers could manage more frequent sessions and where he would benefit from this. Or it may become appropriate for a child in intensive analysis to reduce to less frequent sessions. The lack of prospective research remains an issue that the profession must address. So the debate about the choice or efficacy of intensive vis-à-vis non-intensive work will otherwise remain theoretical or a matter of personal assumption.